Hey, everybody. My guest today is Professor Thaddeus Mason Pope, and we're going to talk about voluntary stopping eating and drinking. All right, Professor, why don't you introduce yourself?
So I'm Thaddeus Pope. I'm a law professor at Mitchell Hamlin School of Law in St. Paul, Minnesota. And I write a lot about health law and issues in bioethics, especially at the end of life.
Wonderful. Okay, so let's start with the basic question. What is voluntary stopping eating and drinking?
So we call it VSED, the acronym Voluntarily Stopping Eating and Drinking, VSED or VSED, which is pretty much just what it sounds like, which is somebody just stops eating and drinking. And of course you need, especially it's the drinking that really matters, but you really need water. Otherwise you'll die from dehydration. And that's the point. So this is something that people have been doing for thousands of years, but has been getting a lot of attention recently in Europe and in the United States as a method for people to hasten their death when they're facing serious illness. So, for example, dementia, and you see that your dementia is progressive, and it's going to get to a point where you're going to have a life that you don't want to live, a life that you would find intolerable. So the idea of VSED is, well, today I'm going to stop eating, drinking, and you will die. Anybody will die from dehydration in about 10 to 14 days.
Okay, that makes sense. So would you say that the purpose of VSED is to cause your own death?
Yes. So it's, to give you a better definition than I just did, perhaps, it's the complete cessation of all food and fluids by mouth. You're able to eat and drink, so it's not like you have some kind of physiological problem. You can eat and drink, but you make a deliberate and intentional decision to stop doing that. And then the third element would be what you just said, which is the intent or motive in stopping all eating and drinking is to cause your own death, right? So it's those three things. You're able to eat and drink, but you stop eating and drinking, and the purpose and intent is to cause your own death.
So would you say that it is a form of suicide?
Well, that's more controversial. And there's a big debate in the medical and the bioethical literature about whether this and other forms of hastening death are suicide. I think it depends on who's doing the VSED. So, let's do it in two parts. First, yes, you are engaging in conduct that causes your death. So strictly speaking, it's suicide, right? You are causing your death. But in common vocabulary, right, common usage, suicide is often done by people who are irrational, acting maybe because of mental illness or acting rashly. And importantly, they're not already dying, right? The thing about the VSED patients is they are already facing cancer or a death from something else. And so they're already dying. And the VSED doesn't change somebody who is going to have a life into somebody who's going to be dead. It's just somebody who they're already about to be dead. The VSED only changes the precise timing and manner of the death. And that's why many people think, therefore, it's inappropriate to use the word suicide when talking about VSED or relatedly medical aid in dying. So I think it has a very negative connotation. Most people that have VSED get informed consent and guidance and supervision from licensed healthcare professionals. So it's a very rational decision. So I think it contrasts with the paradigm of suicide in a number of respects.
Okay. So you said that it's gotten a lot of attention recently in Europe and the United States. Why is that?
Well, because it's first of all, it's part of a broader wave of discussion. So we, as a society, both in the United States and in Canada and in Europe and in Australia and New Zealand, are talking more about death, right? We're willing to think about what are our rights to control the timing and manner of our death. So most of the attention, the public attention in the community as well as in the legislative halls has been about medical aid in dying when a physician either gives you a lethal injection or gives you a prescription for lethal medications. But we recognize that the terms on which MAID or medical aid in dying is available are limited. right? So in the United States, 11 states have authorized medical aid in dying. But what about the other 45 jurisdictions in the U.S.? And even in the 11 jurisdictions that have authorized MAID, it's only available on certain terms and conditions. So there's many, many patients that are facing deaths that they find intolerable, and MAID's not going to be available for them. And so then they ask the question, well, then wait, what is available? They ask their doctor, they ask their lawyer, they ask their bioethicist. I can't have MAID. What can I have? And so VSED is sort of the lead backup second choice alternative.
I see. That makes sense. So isn't VSED something patients could have already done? Like, is there like no legislation on the matter? And so now it's becoming a discussion. Now there's all these efforts to pass certain laws.
That's a great question. So again, I'll contrast this again with MAID because it's the more salient option, at least in the United States. You absolutely need a physician to have MAID because these are controlled substances, and the pharmacy is not going to give you the medications without a prescription, right? So you need a physician, you need a pharmacist, right? So you need all these licensed healthcare professionals to get access to the medications. With VSED, right, you or I right now could just decide to stop eating and drinking today, and in 10 days we'll be dead. So you're right. You're absolutely correct. You do not strictly need a licensed healthcare professional to engage in VSED, but it would be risky to do that because it's going to be uncomfortable, right? So you want somebody who has expertise in palliative care to supervise this. You're going to have obviously symptoms of thirst. You're going to have, anxiety, and normally on top of that, the people that engage in VSED have the underlying illness, whether that was cancer or and so you're going to have all the symptoms from the VSED itself as well as the symptoms from the underlying illness. You're going to want somebody who knows how to manage that suffering to be supervising your VSED process. You're right. You don't need them, but you're going to want them.
I see. So the VSED legislations that are now being debated involve assistance from healthcare professionals.
Well, actually, I should jump in on one thing. There's not a lot of VSED legislation being considered. The idea basically is that there's already a general rule that anybody can refuse anything. This has been settled in bioethics and in the law for many decades. That if you don't want a mechanical ventilator, if you don't want dialysis, if you don't want CPR, whatever. If you don't want something, nobody can force you to do something or take something that you don't want. So the general understanding is we don't need a law to authorize that because it fits within the umbrella of a broader rule already. But maybe we'll come to this. There is legislation being considered for advance requests for VSED. So it's one thing for any patient to say, patient with capacity, with decision-making capacity, to say, today I'm going to VSED, and they start. But sometimes what you're afraid of is not what you're facing today or tomorrow, but what you might face in 6 months, a year, or 5 years. And the problem, though, is that at that point in time, you may not have capacity to VSED. So you leave instructions in an advance directive to say, when I get to the point where I don't recognize my family, I can't communicate with my family or anybody, or I can't go to the bathroom, or all three of those things, then, and I'm dependent upon nurses or somebody to feed me, I direct you not to feed me. I'm going to be dependent upon that, but I'm telling you not to do it. Well, so when you're directing VSED for yourself, not contemporaneously, but through an advance directive, yes, then you do need legislation to authorize that, because all the rules about who is an authorized decision maker on your behalf, what are their powers, what's the scope of their authority, that's all defined by statute. And so there is some legislation this year about clarifying somebody's ability to direct VSED through an advance directive.
Okay, so that sounds similar to just refusing artificial nutrition and hydration, right? Except you're not being fed through tubes. This means that you just don't want being fed through your mouth.
Yeah, so that's absolutely right. So one of the most famous cases in all of bioethics is the Nancy Cruzan case, from 1990, where the U.S. Supreme Court sort of said that you have a fundamentally protected right under the U.S. Constitution to refuse, again, any life-sustaining treatment, but in that case specifically concerned artificial, or sometimes called clinically assisted, nutrition and hydration. And that's delivered through either a nasogastric tube or gastrointestinal, different types of routes to get the stuff in your body. This is just one more route. It's just your mouth instead of a tube. But right, that the idea is it's analogous to that.
I see. Okay, that's interesting. So you're saying that the legislation right now, it's not really about VSED for a patient who has capacity. It's about VSED in the context of an advance directive.
Yeah, the understanding is we don't need legislation to authorize "quote unquote" regular VSED, because it's everybody. And I mean, I do a lot of talks that go around. Generally, everybody thinks, yeah, that's absolutely legal. There's no problem with that. There's no problem with the patient doing it. There's no problem with the doctor helping the patient do it. And so most, in terms of legal reform, most of, not all, and we could talk about why there might be a need for regular VSED legislation, but most of the attention has been on legislation for advanced VSED.
Okay. So as seen or as understood as kind of like a one way of controlling one's death, right? It seems that it's subpar in comparison to something like physician-assisted suicide or euthanasia, because you said, it might take like 10 to 14 days for you to die from VSED, right? So in that sense, is it just kind of like the second best?
For most people, not for everybody. It does take a long time, and obviously it can be uncomfortable to die from dehydration. But there's a fair amount of actually good evidence, in peer-reviewed journals like the New England Journal of Medicine, that shows that some people who have both choices available to them choose VSED. Sometimes that's because the patient has their own moral problems with medical aid in dying or euthanasia. Sometimes it's actually thought that the slowness is actually better. There's a grieving process. There's time to sort of say goodbyes. So for whatever reason, some people actually think that it's superior, not inferior. But I'll grant you that if we took a poll or a survey, most people would prefer MAID or euthanasia to VSED. Sure.
Mm-hmm. Okay, I see. So it's not, even though most people may prefer, physician-assisted suicide or euthanasia, VSED has its own benefits that could, depending on the person, be preferable. So no matter what, VSED should be available to everybody.
So, I mean, to put a real strict point on this, the Netherlands, which has a pretty broadly accessible euthanasia program, they still have maybe 2% of all deaths in the Netherlands are from VSED, which is, and the rate of deaths from euthanasia is only 4 to 5%, right? So it's a lot of people are using VSED, even though euthanasia is available on pretty broadly accessible terms. And you see the same data. It's not been measured everywhere, but where it has been measured, you find the same thing. So people who have both choices available, a good number of them, and I'm not exactly sure why, but a fair number of them choose VSED.
So do you think that if VSED becomes a more commonly accepted thing and something that's protected under the law for in advance directives, do you think that takes away a lot of the importance on winning this euthanasia battle?
So that's a good question. So this gets a little bit beyond the academic questions. In bioethics, maybe it's more of almost a political question. So when you look at the debates, in many states every year we'll have 10, 15, 20 hours of legislative hearings on medical aid in dying. And VSED is often, if actually not even just often, regularly criticized. And so it's used as a way to justify the need for medical aid in dying. So people will often say, my mom died from VSED. It was so bad, right, that we need to pass this bill authorizing medical aid in dying so people don't have to die from VSED, right? So that's often the way that VSED is framed. So now I don't know if those people, if they had a bad clinician, if they didn't have good clinician supervision, that their VSED experience was bad because of the way that they did it. It's not intrinsically necessarily bad if it's managed by competent palliative care clinicians. No, I don't think it's going to, but I don't think it's going to moot the debate or the need or the call for medical aid in dying because, well, as we just discussed a minute ago, most people still think that that's a superior option because it's just way faster.
Yeah, that makes sense. So do you think the people who are opposed to medical aid in dying are also opposed to VSED on ethical grounds? Or do you think that they are accepting of one but not the other?
Oh, good question. Well, first of all, most people opposed to one are opposed to the other, right? So the main people opposed to medical aid in dying would be the religiously affiliated organizations, especially the Catholic Church and Catholic affiliated healthcare. They're opposed to both. And the second biggest group opposed to medical aid in dying are disability rights organizations. Not exactly sure where they come out on VSED, but I think the alignment's not going to be perfect, but it's going to be a pretty big. If we had the Venn diagrams, they're not going to be on top of each other, but the overlap of the Venn diagrams is going to be pretty close to 100%.
Okay. So what are the tricky ethical questions when it comes to VSED and advanced directives?
There's a lot of them, so we could do them one at. I'll start with what I think is the single biggest one. Okay, which is so let me just do this real slow and unpack it. So let's say I'll just take myself, right? Let's say I'm afraid. Actually, this is just coincidental, but I happened to have test driven an advanced VSED directive today. So somebody said, will you take a look at it? I went through it. It's sort of a one where you read it and then you click the statement that you agree with. And then when it's all done, it prints out the directive given the choices that you made, inserting the text that you want. So I literally did this today, saying, if I get to a point where I'm in a late stage of dementia, stage 6 or stage 7 Alzheimer's, and I can't do all these things that make my life meaningful, don't spoon feed me, don't hand feed me. Okay, so let's say that time has come. Whoever's taking care of me at that time has my directive, and they said, yeah, we'll honor this. Stop giving him water. Well, what then, for whatever reason, me in my severely demented state says I'm thirsty, or makes some kind of gesture indicating that I would like some water. So then the question is, for whoever's taking care of me, is do we honor his directive that he wrote years ago, back when he still had decision-making capacity, or do we honor the Thaddeus Pope in the bed right now this afternoon? And I think that's a big debate, and that it's been going on for a long, long time. Not about VSED, but this idea of which self, the former self or the present self, do we listen to? And that's an old debate between Ronald Dworkin and Rebecca Dresser, but it's sort of been revitalized even this very week in the pages of some of our best bioethics journals.
Do you side with one or the other?
So I do side. I guess I do. I've always found Dworkin's arguments on this more persuasive than Dresser's. I also think that when somebody lacks capacity, that what they say or do or doesn't have much evidentiary value. So in other words, I think that after careful reflection, careful deliberation about what Dworkin calls your critical values, that's what we should follow. Not when you say you don't understand what the consequences are when you, in your demented state, say, hey, I'm thirsty. Well, you don't know that that's going to prolong your life for another year, and whatever the consequences you want to fill in there. All that money to stay in the long-term care facility, that's money that's not going to go to your favorite charity or to your grandchildren or whatever. So you're not aware of the consequences of the decisions that you're making when you're in a late stage of dementia. So I don't think that those utterances or gestures count. And therefore, I would follow the directive and ignore what the person in the bed today is doing or saying.
Yeah, that's a really tricky one. I know this question arises for other types of care as well, And I feel like this ethical issue, one part of it is essentially metaphysical, I feel like, right? Which is, there is this person in front of me now, and this person in some important ways is not the same person that he was maybe 2 years ago even, right? Do you think that that question even arises, like whether or not this is the same person? Because if it's not the same person, then that advance directive wouldn't even apply.
Yeah, so that's right. That's another way to go at it, right? The one is I guess the one way to frame it is it's a revocation, right? Whatever the advance directive was, it's been revoked by the person. And I don't think that works because they lack capacity. And normally you need capacity to revoke an advance directive. Your another way to go about it is what you just said, which is sort of a personal identity approach, where the advance directive was written by a completely different person, right? So obviously your advance directive doesn't affect me because it only affects you. You can't write in an advance directive for somebody else. I get that the person has changed a lot. I've never liked the personal identity argument because, and maybe this is because I'm a law professor and maybe I think about these too legalistically, but if you really wanted to push that out, then if we're going to throw out advance directives, why don't we throw out other stuff like debts, student loans, right? You say, you know what? Back when I took out all those student loans in my 20s, I thought I was going to be an architect. I'm a different person now, so I shouldn't have to pay for the 20-year-old person that thought they're going to be an architect. You know what I mean? I think there's I guess it's like a reductio problem with that argument, which is people change in lots of ways, and it doesn't sort of get them off the hook of commitments and duties and obligations that they assumed, by their earlier selves.
Yeah, that's interesting. Yeah, maybe you are thinking about it more like a lawyer, and I'm coming at it more like a philosopher. One distinction I would make between those things is that I would say, and I don't know, this is just my guess, that it's very different for somebody to suffer from like late stage dementia than it is for somebody who changes what their dream job is. You know what I mean? Like there's still the psychological continuity aspect and the latter case that isn't there in the former case. So I would say that gives more of a reason to think that a person suffering from late stage dementia is actually a different person. But again, I don't do metaphysics. It's just something that, I know people have raised, and I think it's an interesting question, and I don't have the answer.
It is what's being raised because that, like I said, that whole debate has been revitalized in a very real way. I mean, in the journals and even hospital ethics committees, because they have patients show up with a VSED advance directive, and they literally have to figure out, are we going to honor this thing or not? Right. So this debate is really happening. I think there's another response I want to make, though, which is I think because a lot of what Rebecca Dresser talks about is that there's a lot of prejudice. So maybe you or I, or a lot of people, don't really have a good understanding of what dementia is, and where, and I think with today's decision-making tools, I think we can have a better sense of our future selves, right? I mean, there's videos to watch. There's even virtual reality where we can see, oh, this is you. We projected you as an 85-year-old, right? And now you have a better sense. So you are making decisions for your 85-year-old future self, but I think we can make them better informed decisions. And so I think that helps. I'm going to use the metaphor, close the gap between the former self and the future self. So I feel better. I do feel bad if the decisions controlling the future self were underinformed or driven by prejudices or stereotypes that were wrong. Then I think the case for not honoring the advance directive is stronger because, well, the person didn't really know what they were talking about. But if we could say, no, it was a very careful process where they had a good understanding of what their future self might be facing, I think those better informed decisions that are memorialized in the advance directive should be honored. But yeah, it's the problem is, just to put a real, give it a little bit more color, is you decided back when you wrote the advance directive that life in this situation would be intolerable and you would be suffering. But now people standing over your bed are looking at you and you appear perfectly content, if not happy, right? So what they're saying was, well, the reason that he wanted to VSED at this point in time is because he thought he would be suffering. We are it doesn't appear that he is suffering, right? So the sort of the premise or the reason for the VSED has not obtained. The answer to that actually is most advanced directives, not just VSED directives, but most advanced directives give you the ability to give your agent, your healthcare agent, some amount of discretion. And so I think many of these would say, hey, if I think that I would want VSED at this point in time, but I'm going to give you a little bit of discretion, healthcare agent. If you think that I'm doing okay and I'm not suffering and I appear content and I like ice cream or whatever, then don't do the VSED, right? If you think I'm okay or if I'm not suffering. So I think that's one out. Sorry.
Yeah, no. So do you know if any of these advanced directives are written as Ulysses contracts?
So some are, right? So when you stop feeding me, I might ask for water. And then but right, when you complete the advanced directive, you anticipate that situation and you say, even if I ask for water, don't you do it. Listen to the person writing the directive, don't listen to the future person. Some states, like Vermont, in their law, specifically authorize VSED directives, specifically authorize Ulysses clauses. So you're allowed to basically, the law literally allows you today to veto the future self. So it sort of clarifies that the future self doesn't count or can be overridden by the former self. Most states don't have Ulysses clauses, or at least as explicitly as Vermont. But that does help resolve well, it's not going to satisfy some people, right? Because they're still going to say, well, I know the law allows you to have a Ulysses clause and the law allows you to override your future self, just like Ulysses did. But I still think it's wrong. I don't think you should be allowed to override your future self.
Yeah, it definitely gets tricky in those cases. 'Cause I know that for in other cases of advanced directives, there have been times where surrogates have overridden the patient's previous wishes because the clinical situation has changed. And I'm wondering if something like that would also apply to VSED.
Unfortunately, surrogates override advanced directives all the time, not just where the situation has changed. And unfortunately, clinicians follow the surrogates. Big problem. So I think if there's an advanced directive that says, I never, ever, ever want to be intubated, right? Never, ever, it's super clear. The surrogate is going to need one really strong and compelling reason for why we should not honor the strict, instructions in the directive. I do think that the Ulysses clause helps avoid the problem because it's to take your example now with the surrogate. You can't say, oh, she didn't anticipate this. She didn't anticipate this situation. So I think we should move away from the advanced directive. With the Ulysses clause, she specifically anticipated the situation and gave us instruction and guidance as to how she wanted that conflict resolved. She thought, oh, whoever helped me complete this advanced directive was smart enough to give me a heads up that there might be a contradiction between what I'm asking for in the directive and what my future self is going to ask for. I'm telling you, it's my body. I'm the drafter. I'm telling you how I want you to resolve the contradiction. So I think if you do that, I think you preempt or eliminate any space for your surrogate to exercise some discretion there because you already told us how you wanted us to resolve the conflict.
Okay. So in terms of the practice of VSED, then this would happen in hospitals and at home?
Probably rarely in hospitals because typically, well, let's break it down. First of all, probably it does happen in hospitals, but I think rarely. I think it happens a lot even right now in long-term care because the sorts of people who are likely to use VSED are older. So people who use medical aid to dying are maybe average of 67, maybe between 60 and 70 for the most part. People who use VSED, in contrast to MAID, are like 80, 85 plus. So it's an older population, but I think it's typically home hospice or long-term care, probably less likely to be a hospital.
I guess I'm trying to see whether or not something like VSED, or there could be different versions of VSED, right? So if the goal is, look, like I don't have access to MAID and I want to decide my own fate, and one of my options is to just refuse nourishment, then there must be all these other things that I could refuse that would hasten my death even faster, right? So would that be something else?
Absolutely. The problem is most people aren't dependent upon those things. So that's yes. If you have end stage renal disease, just stop dialysis. Right, you'll be dead pretty fast, faster than VSED. If you're on, I mean, so yeah, we could. There's a long list of things that you can refuse, and secondly, the refusal of those things will cause your death because, at least for you, they were life sustaining things. The problem is, at least if you look across the population as a whole, most people aren't on those things. They have a right to refuse them, but they don't have it. They don't have an LVAD. They're not on mechanical ventilation. They're not on dialysis. They could refuse antibiotics, but they don't have a pneumonia or an infection. So yes, but for the patients that do have one of those devices, or they're dependent upon some form of life-sustaining technology, they can refuse that technology, and that will lead to their death. Yes.
I'm trying to think of like the another tricky ethical issue here. So I know that one of the objections against euthanasia is that you need some healthcare provider to intend the patient die, right? That there has to be one, assistance from somebody else, a healthcare professional, and two, there has to be intention to cause a patient's death, right? So VSED, right, kind of gets somewhat around this, right? Because it's not like there's some lethal injection. It's not like you're swallowing this lethal medication. It's a refusal of something basic, and it's protected already legally because patients already have the right to refuse almost anything, right? Like other life sustaining care, right? So in that sense, it's different. But if what you're saying is that a physician or some healthcare professional still has to participate in a way, right? Maybe there's still an ethical objection there, right? Because it's not just that the person is not eating or drinking, is that you are also making them comfortable so that they can sustain their voluntary stopping eating and drinking.
Yes. So yes. So you're not it's definitely different than, well, we could break them up by a spectrum, right? So euthanasia, like in Canada, the physician uses an IV, right? The physician is actually causing the patient's death. And she knows that's what she's doing. And that's and it's the point. Okay, that's at the one end of the spectrum. Move back from that just one step to what we have in the United States, which is not euthanasia, but it's medical aid in dying. So there, all the physician is doing is writing a prescription for the patient. The intent there is a little bit messier because a lot of patients, maybe as many as 40%, don't take those medications. It's like an insurance policy. If their symptoms get worse, they want to know that they have those meds on hand. But for many, their suffering is manageable with hospice and palliative care, and they never need the meds. So the physician, I think, could write a prescription in the United States thinking, I hope the patient never needs to take this. So they're not aiming to cause the patient's death. They're aiming to give the patient peace of mind and comfort, but knowing that the patient might use those meds to hasten their death. And then moving down one more step to VSED, as you said earlier, the patient doesn't need a doctor to do this. The patient can just do this on their own. So the role of the physician is not to cause the death in any way, not causally involved in any way whatsoever. The patient is the causal agent, and the physician is there just to provide comfort, to alleviate physical suffering and maybe existential suffering. Although maybe I'll put a footnote to that one. Some patients might not proceed with the VSED until the physician is on board, in which case the physician's involvement is like a but for or sine qua non, right? Which is I'm not. So they're by agreeing to participate or not agreeing to participate, they are sort of opening the door or not opening the door to the patient's VSED. So somebody could say that that's causal, but they definitely are less. I think there's a lot of polling data on this. The physicians on the euthanasia, very few would support euthanasia. When you move to medical aid in dying, the support among physicians gets higher. You move to VSED, support gets even higher because they feel less morally complicit, right? I'm not doing this. You're doing it. I'm just helping you feel comfortable while you're doing it. But absolutely, many physicians they would even use the word murder, right? You're helping to murder the patient. So it absolutely not free of ethical condemnation.
Yeah. All right. So I'm going to get a little more hypothetical here. So everybody needs to eat and drink to survive. everybody also needs to breathe to survive, right? So instead of VSED, let's say it's voluntarily stopping to breathe, okay? We have this urge to breathe. It's really hard, if not impossible, to suffocate yourself like that, right? To just stop breathing. And so the doctor has to help give you something to suppress your urge to breathe so that it's still like a choice, right? And that leads to your death. Would that be analogous?
I'm trying to think of what the mechanism. So let me make sure I got it. So what is the doctor doing? Or just tell me one more time what's happening.
Yeah.
Here.
So if I'm understanding VSED, right, the doctor is there to provide you comfort so that you can sustain your not eating and drinking, right? Because I mean, I think it would be really hard to starve myself to death or to dehydrate myself to death, right? So if they can give me something so that I feel comfortable, then that enables me to die via VSED, right? And so I'm thinking, like, what if there's an analogy to be made there with breathing, right? It's really hard to just die by choosing not to breathe because there's this primal biological urge to breathe, right? So what if they can give me a medication that would suppress that urge to breathe, and then I could cause my own death by holding my breath?
Yeah, I guess I'm not. I get it. Okay, I guess I'm not quite sure of the clinical. I mean, first of all, morphine. This has been actually a debate for a long time, which is giving somebody large amounts of morphine will cause, or at least is thought to cause, respiratory depression, and therefore basically cause you to stop breathing. Now, and that's where people always bring up then the double effect, the doctrine of double effect, which is, well, if the doctor were giving you that morphine because you had pain and suffering that was intractable to lower doses, then the fact that it caused you to stop breathing is totally fine. But if she's, which I think if I understand your hypothetical, if she's giving you the morphine for the purpose of helping you to stop breathe, then you can't hide behind the doctrine of double effect. She killed you. Although maybe what you're saying is the drug that she's giving you didn't cause you to stop breathing. It made it easier for you to, and I guess this is where it maybe becomes scientifically not grounded. It makes it easier for you to stop breathing. I don't know that you can will yourself to stop breathing the same way you can will yourself to stop drinking. But if it were possible, yeah, then maybe that would be analogous.
Yeah. I'm like, this is just a thought experiment. I don't even know if it's scientifically possible or if it will be possible. But there's like a distinction that I think I want to make there, right? Which is one, that the medication is not directly causing the death, right? The medication is suppressing the negative subjective experience that would make me break my willpower, right? So it would have to be analogous to that. So whatever medication that you would need to give somebody such that their willpower to not breathe would win at the end, that is what would be analogous.
Yeah, although I guess, okay, I agree, I get it. The only thing I want to push back on a little bit is the word willpower, because that suggests that it's affecting your decision-making capacity. At least to me, when you use the word willpower, right? I think the patient in the VSED process people stop, right? So we're not impairing their ability to change their mind or anything like that. So we're making them comfortable so they don't quit because it's too hard and too uncomfortable and painful. Or, but I don't know that I would want to say we're affecting. At least I would want to think about whether I would want to use that word, because it suggests that you're affecting their cognitive. It sounds like duress, right? That you're affecting their ability to change their mind.
Yeah, I'm not committed to using that word. It was the first one that came to mind. Basically, it's just like, I would find it really hard to starve myself to death. Like, it's just so uncomfortable to be hungry. It's so uncomfortable to be thirsty. Like, I feel like I would give up multiple times, because it would just be so uncomfortable, right? So then I would need some sort of help from somebody else to keep me comfortable. And I just thought that, I don't know if that would be possible for something like, breathing or not, right? So somebody just give me something to be comfortable so I can just die through, via lack of oxygen,
Yeah, I get it. And I think, yeah, I mean, I think it would be, sometimes it is absolutely helpful to do these analogies to see what that contrast illuminates for what we think about VSED, I think it actually might be worth doing. But it's worth noting, just as a matter of context, that there's actually a lot of talk about dying from lack of oxygen. There's a case going up on appeal to the Supreme Court, right? Because we're going to have our first execution by nitrogen. So the idea is we put a mask on this. This is a guy who's been convicted already of murder years ago. Put a mask on him, and it's just regular air. But then over a few minutes, it becomes 100% nitrogen, which of course means it's 0% oxygen. Apparently, this is the state's argument. You're not going to notice that. So it's not, you just sort of pass out because but it was imperceptible as it went down from, I think the regular air that you and I are breathing right now is 21% oxygen. It just goes down to 20, 19, 18, 17. And as that happens, you're going to be getting less and less oxygen, but it's so gradual you don't notice it. You just pass out, and then sometime after you pass out, you'll just die, of course, because you still aren't getting oxygen. Anyway, the debate is that actually as comfortable as it sounds, because the prisoner and his lawyers, of course, are arguing that violates the Eighth Amendment prohibition on cruel and unusual punishment. So we are literally debating, like this week, about killing people. Now that's of course involuntary, not voluntary, like VSED. But can we kill people through depriving them of oxygen?
Yeah, I should clarify that this interview is taking place on January 19th, 2024. So just for the listeners. Yeah, so I didn't know about this nitrogen execution method. It kind of reminds me of Dr. Kevorkian, because I think he used carbon monoxide for maybe like at least one of his patients.
Well, a lot. So Kevorkian, at first, it's worth noting, it was always what we would call, it always fit the American model, not the Canadian model, which is at first he would have the different drugs, and it would be set up to go into your vein, but you would have to roll the thing to open the valve so the drugs could flow from the bottle into your vein. So it's always patient initiated. He then, after the first several patients, he lost his license, so he couldn't obtain those drugs anymore. So then, yes, then you're right. He used that.
Yeah, it sounds like that if something like physician-assisted suicide or euthanasia were legal, then people wouldn't have to resort to doing it, themselves at home.
Well, yes, but I think it's worth remembering it's not binary, right? It's not like, is it legal or is it not legal? It's legal under certain conditions, right? So are you terminally ill? Do you have a 6-month or less prognosis? Are you a resident of California? Are you, and can you find a doctor who is willing to participate? So apart from the law, you then have a whole bunch of very practical and logistical challenges. In fact, in every single state in the U.S., you need an attending clinician and a consulting clinician. So you need to find 2 doctors that have the time. You can get into their practice, have them examine you, certify you as eligible. And so anyway, just to make clear, there are people even in states like California, which have legal medical aid in dying, been legal since 2016, that still will use VSED because either they don't qualify for medical aid in dying under the California rules, or even if they do qualify for medical aid in dying under the California rules, they can't access it, right? Because they live in an area that all the local hospitals are Catholic affiliated and they don't participate, or they otherwise just can't find a willing and available clinician.
All right, I think it's a good time to wrap things up. Thank you so much for being here.
No, thanks so much for having me.